Hello, I'm Dr. Usha Ayyagari. I am a senior consultant endocrinologist in Chennai, and I'm recording this podcast on behalf of Lupin Sinox division. Over the next 5 to 8 minutes, I will be talking to you about the placement of a combination of linagliptin and empagliflozin and the benefits of using this combination therapy. I'm going to take a case-based approach to this podcast. This is a patient I've seen. He's male, he's 48 years old, has diabetes for 2 years, and is known to have hypertension and dyslipidemia. He's mid-level management executive, has a relatively sedentary lifestyle, and exercises only sporadically. Currently, he has a BMI of 29. His A1C is 8.6. His serum creatinine 0.8 with a GFR of 90, and his blood pressure is 140/80. His current medication includes metformin, 1000 milligrams twice daily, a combination of calcium channel blocker and angiotensin receptor blocker for blood pressure, and a statin for his dyslipidemia. He also has a family history of MI in his father at the age of 54. So this gentleman, although he's under the age of 50 and has had diabetes only for 2 years, automatically goes into the high-risk group because of his BMI, his relative sedentary lifestyle, his comorbidities, and his family history. Now, in this kind of patient, what should be his target HbA1c, blood pressure, and lipid values? What is the best second-line treatment to control these? How do we get to target and maintain target? And how do we reduce his future risk of comorbidity? These are all the things that we need to address. Now, we know that in people who are on metformin, by about 9 to 10 years after diagnosis, only about 12 to 13% of people on metformin alone are well controlled and have an A1C under 7. If you look at sulfonylureas, we know that by 9 to 10 years after diagnosis, less than 25% of patients on sulfonylureas remain well controlled. And why is control important? Because we know that poor glycemic control increases the risk of complications. And we know that for every 1% reduction in HbA1c, and this data is from the UK PDS study, we know that there is a 12% reduction in any diabetes-related endpoint, 25% reduction in microvascular disease, and 16% reduction in myocardial infarction. When these same patients were followed up 10 years later post-trial and without any active intervention, you saw that the diabetes-related endpoints were still reduced by 9% in the active group compared to the comparator group, microvascular disease by 24%, and myocardial infarction by 15%. So what we know is that in type 2 diabetes, glycemic control reduces long-term complications. And it's not just glycemic control. The earlier you get good glycemic control, and this is what we know from data, the longer you can keep complications at bay. Now, in our gentleman with hypertension, dyslipidemia on metformin with suboptimally controlled diabetes, what are our options? You all know about the ominous octet, and ideally in this patient, of course, the metformin acts at the muscle and the hepatic glucose production level, maybe 2 out of the 8, but I would like to hit as many targets as possible in the next round of therapy. So if I look at this particular combination of linagliptin and empagliflozin, so a DPP4 inhibitor and an SGLT2 inhibitor, the DPP4 inhibitor will address the alpha cell dysfunction and address the increase in glucagon secretion. It will also give me a little bit of extra boost in terms of insulin secretion, which is glucose mediated from the pancreas. It will give me a reduction in hepatic glucose output. There is a boost of the incretin effect at the gut level. So these are the targets I can hit with the DPP4. And if I look at the SGLT2 inhibitor, it gives me a mechanism that's completely independent of insulin action. So you reduce the glucose reabsorption at the level of the kidney, and indirectly you benefit insulin sensitivity and glucose uptake at the level of the muscle. You also have indirect effects on the pancreas to improve insulin secretion. So out of the 8 potential mechanisms that we now commonly talk about, the ominous octet, this combination of SGLT2 inhibitor and DPP4 inhibitor will allow me to hit at least 6 out of the 8 targets in combination with the metformin. And Therefore, this combination I know works from a pathophysiology basis. Also, remember I told you that his HbA1c was 8.6. Now, any one oral agent that I give him will at the most, and this would be a sulfonylurea, help me reduce his A1c by 1.5 to 2%. And none of the other agents will give me that kind of a magnitude of effect. And therefore, bringing this gentleman, for whom ideally I would like to achieve and maintain an A1c under 6.5, if possible, without any hypoglycemia. It would be very difficult for me to get this kind of a control with the addition of any of the other agents. But putting together a combination therapy might just allow me to achieve the target HbA1c level. And this combination of DPP4 inhibitor and SGLT2 inhibitor can give me an A1c reduction of up to 1.5%. But apart from the absolute reduction in A1c, there are a few other benefits. Remember, I've told you about his renal function being normal. So perhaps the SGLT2 inhibitor might help me preserve his kidney function and protect this from deterioration in the future. Also, he has established hypertension and dyslipidemia, as well as a family history of premature CVD. So cardioprotection comes into play here, and we know that the latest guidelines recommend that in somebody who has established ASCVD or is at high risk of ASCVD, we should certainly be considering the SGLT2 inhibitors as a class. And we know that empagliflozin also has an independent license from the FDA for reducing CV mortality as well as morbidity. So again, from the cardiovascular risk reduction point of view, this combination of linagliptin and empagliflozin will allow me to manage multiple pathophysiological mechanisms. We also know that this fixed drug combination will give me better reduction in A1c than any single drug on its own, and it will also help me reduce the pill burden for the patient. So in terms of adding a number of agents to his current existing metformin, I can add a single fixed drug combination of linagliptin and empagliflozin and help bring his HbA1c down. We also know that the HbA1c reduction with this combination is durable. So I get early reduction in HbA1c within the first 3 months, and this reduction will then be maintained out to the future. Finally, I've told you that he has a relatively sedentary lifestyle and has a BMI of 29. The DPP4 inhibitor is weight neutral, and the SGLT2 inhibitor may give me a little bit of benefit in terms of weight loss. So putting all this together, in my opinion, for this particular gentleman, minimizing his cardiovascular risk, preserving his kidneys, minimizing weight gain with very low risk of hypoglycemia, a fixed drug combination of empagliflozin and linagliptin is perhaps one of the better options to improve his glycemic control and long-term comorbidity. In terms of side effects, we do have to take into account the potential side effects of genital tract infections. We know that SGLT2 inhibitors have a slightly higher risk of especially mycotic genital tract infections. But remember that when combined with the DPP4 inhibitor, this risk seems to be reduced and mitigated. So this is one advantage again of putting together a DPP4 inhibitor with SGLT2 inhibitor. So putting all this together, we know that the risk of hospitalization with heart failure, CV death, 3-point MACE and renal outcomes all are addressed by this dual drug combination. I hope that this has given you a little bit of insight into my approach to a patient with high CVD risk, and hopefully this will generate a little bit of discussion and debate as to what potential other options can be. Thank you very much.